All right. Well, Happy New Year. Thanks for joining us today. Hopefully, it's a little warmer by you than it is over here in Chicago. Um, this is our January community conversation. Really excited to have you all here today. We're going to be talking about Epic and documentation and using Epic for PCBH and COCM. So, looking forward to just hearing from you and ways that's going. We have someone from CFHA here with us, Daniela Hernandez, who's going to kick the conversation off. So, Daniela, just turn it over to you.
Awesome. Thank you, Stacy. And
Mhm.
good morning, everyone. I am in California, so it's morning for me. Okay. I hope everyone is doing great. It's nice to see so many names and faces that I recognize here. So, this epic community conversation, it's been a long time coming. I think we last had one of these last year around this time as well. And what we quickly discovered was that not one version of Epic is the same. It is different. Ben, you're laughing. It is different across every organization, even if you're within the same organization, your user preferences and favorites can be different from one person to the next. So by no means am I laughed when I read that I'm a super user of Epic because I question that. I just have been in at one point, I think I had 7 different logins for 7 different versions of Epic. And every version of Epic, I was doing a different workflow for COCM. So that just gives you some insight as to how different every process workflow can be within Epic. And we wanted to bring everyone together more or less to pick your brains and see what losses and what wins you've had, what struggles you are facing right now. And hopefully we can come up with some solutions or at least lead some folks on the right path to help them out with both their COCM or PCBH programs within Epic. Um, Let me see. I had a few little prompts here. Let me share my screen with you all. If you want to turn on your video, by all means, do that. If you want to come off mute, please just do that. This, by no means, is this a super formal presentation. Just for the sake of having something on the screen, though, I put these little slides together. But I definitely want this to be a conversation and a learning experience for everyone. We want to be able to highlight some successes, just some best practices that we have, definitely the struggles, and just being able to identify some resources, or if anyone here has templates or workflows that they have used and have been successful with, let us know. I know Martha and myself have also shared several templates for participants that are in Documentation Palooza that we do every year. So I know several people have used those templates to create templates within Epic for both PCBH and COCM. Um, just some ideas of what we can think about is, again, using some of those templates, having that structure for our staff to be able to streamline that documentation, embedding different surveys, um, using different dashboards. I know one of my organizations out here in California, their director for PCBH is a whiz with Epic and dashboards, and her users, her staff can pull up these dashboards quickly to see how long their typical touch points with patients are, how many warm handoffs versus follow-ups are happening. And that is really used for in the moment training and, improving of the services that they're providing to their patients. So let's open up the floor right now and see if anyone has questions or experiences, and we'll go from there.
Hi. Everyone, I'm Molly, coming from outside of Philadelphia. So it is cold here. I maybe just to get the ball rolling, I am curious. I'm a Epic user. I was identified as a super user when we converted over. However, I'm realizing more and more, and I don't know if anyone in this community can speak to it. Um, that certainly super users vary and what they're actually able to do varies tremendously. But my main question is there something from like a best practices for integrated behavioral health, whether it's PCBH or COCM, that comes directed from Epic? So I see your head shaking. The reason why I ask is what I face is that in my organization is being told that this is what Epic recommends that we do with specialists. And I face that comment a lot. And my gut is saying that like this doesn't pass the sniff test. But I am curious to know, does Epic offer like a best practices recommendation? Because I know that they make a lot of recommendations when setting up Epic and things like that. Um, yeah, that's kind of my two-parted question, I guess.
I'll jump in here really quick and then I'll have other folks speak from experience. So I think if we back up and zoom out a little bit, we need to remember Epic is designed for the medical setting. And it's just, you're talking diabetes medical, right? And as they have grown and expanded, they have also added mental health, specialty mental health. So we're talking outpatient, SUD, you're having to break the glass every single time, to document for this mental health. And in that grand scheme of things, even though we think we are in the world of integrated care is a very tiny, tiny element of what Epic probably comes across. And what I have experienced and the feedback I've gotten from a lot of folks is that all the recommendations that Epic gives to folks is stemming from specialty mental health.
Mm.
Yes.
I could not agree with you more on
Yeah.
that, and it's infuriating.
A-
So
And I
do we have someone in Epic that we can advocate and
I
lobby?
was gonna ask you, Molly, and make the call. Can we get someone go to Epic and talk to them and make that
Yes,
differentiation? Because I've seen recommendations from Epic, like still recommending you have to break the glass. You have to break like every single time.
break
And
the glass.
yeah,
Integrated care should be a separate or like a separate department. Yeah.
exactly. And
Okay.
so, yes, those are Epic recommendations, but I think that whoever is at Epic is thinking, oh, the typical uphill battle that we have. It's mental health. It's separate. You have to break the glass. So it's without the understanding of what the spirit of integrated care is, regardless of model. It's not there. And I see, Jamie, you shared something. Let me read this really quickly, or if you want to come off mute, if you can.
Sure. Can you guys hear me okay?
Yes, perfect.
So we have Epic also. Sorry, my camera's really high. And they have templates within Ocean, but it was really clunky and not integrated at all. And it was taking just a long time to make all the clicks. So we created our own templates. We don't have to break the glass every time though, but we do have to live in separate departments. So you have to change departments every time that you flip between primary care or behavioral health. So.
Mm.
Yeah, so I think what my other understanding of Ocean is that they do have templates and recommended, workflows, whatever. But I do know that, say, San Diego Community Health, and I'm just making up names at this point, can have a template in Ocean and they can share it with Wisconsin Community Health and interchange. So the trick is knowing what to use, right? So I think if we have the Jamies and Mollys of this world that say we created these templates, let's share those, compare and contrast. Maybe Jamie, yours is working great in comparison to what Epic recommended, but there can even be a step up or a further streamline from that.
There's a question, is Ochin Epic specifically for FQHCs?
My understanding is that it's like an add-on on the package of Epic.
Yeah, I feel like the Epic folks, if they heard from maybe the CFHA folks, would be actually pretty receptive. I think that Epic is always looking for like novel approaches to solving problems within medical settings, like we are. And I think that maybe they could change some of these recommendations because I think the difficulty of like the break the glass or constantly changing between templates. Like we have a good setup right now. The problem is our setup constantly gets like legal and compliance involved. And then people who don't know integrated behavioral health are then asking a lot of questions and we have to like constantly defend the setup, which is fine. We're able to do that. But then the messaging is like, well, Epic says like this isn't how it should be. And I always find that that's a curious response.
Agreed. I think I might have to have a conversation with Neftali. You and I, Stacy, will have to like go storm the Epic building or something and have someone talk to us. You know,
Beautiful campus.
I've heard so much about that campus, but I think it's like I think the question is who do you talk to, right? Or how do you get there? But I completely agree with you, Molly. All right. So I guess my next question, and this was mentioned right now, templates. You know, what have you all done to streamline your templates, or how many different templates do you have? I know within training for both PCBH and COCM, I am a big advocate for templates. I really believe wholeheartedly that if we leave folks to their own devices and just to type up their interactions every single time freehand, it leads to a lot of time documenting and it eventually leads to burnout. You know, it's there's no reason to. And I come from a county mental health services where my notes were we were still I was still with paper charts, by the way, 2 legal size pages for every therapy session, right? And it burns folks out. And definitely with the pace of integrated care, it's impossible. So what types of templates have you all created? What has worked for you? What hasn't?
Good morning, everyone. I'm Hannah. I'm in California as well. And I started learning Epic a little over 2 years ago when I first came to the organization, and it's taken me just about as long to not even perfect the templates, but just make them workable, because I feel like just learning from the PCBH community, and there are other Ochin essays who have shared their templates. So I kind of pull from theirs and take from Documentation Palooza and all of that. So I've kind of like Frankensteined ours that, but we also have a lot of other like coding and billing and compliance requirements for things that we have to include in the notes for our insurance audits, which is has made them really long. So there's like the small PCBH kind of like core template, and then there's all this other stuff we have to do. But it's frustrating because the audits are still based on like psychotherapy notes, and I've had a hard time. I mean, I haven't connected with our payers, but to talk about the differences. But as for our compliance and our coding team, we have to include all these extra clicks and things that just make our notes totally unreadable to the other team. integrated team, even though I kind of created them in the PCBH format. So just a lot of ongoing challenges and lots of different iterations and trying to figure out if it should be one template for initial and follow-up, or separate them, or peds and adults. And so, and then throw in the Healthy Steps grant. So then there's all those different things that we incorporate in the visit. So it's been a iterative learning journey for sure.
Great, thank you. Any other comments?
Molly,
Mhm.
what is that you have found works, as she just shared in the chat?
So this might be our setup, and I think that how you're set up is really important. So we're designated as providers, and as such have templates that help with documentation. So we actually do the bulk of our note in the problem list itself, because the problem list, at least in our Epic, never leaves the patient. So it carries over with them wherever they go. And so we do the majority of our documentation in the overview and the assessment and plan section of the problem list. And then we try our best to do as much as like drop down or like multi-select options as possible in the actual note itself, and then just pull that all over. So Epic can do that in that way. Because I do find, I agree with you, Hannah, like it gets cumbersome, and you can easily get into kind of like a rabbit hole. So we actually have one note. We went away from the initial kind of like in follow-up, and we actually have one note, but the MSC is the only thing that we do differently. Everything, and we use the goals, and everything is in the plan section, and then we pull that over into the note. I don't know if that helps, but that's what we figured out. But again, as I've already said, we have flaws that we come against frequently as well. I don't think that they're flaws, but others do. So
It's always compliance and legal that have to mess up our templates, right? Great. How about, I'm wondering, I was even at the point where I had a template or a quick, like for COCM specifically, I had templates for my behavioral health care managers to fill out when they had a psychiatric consultation, when they left a voicemail, like the tracking of all the activities that they do, so that it was easier. We think that writing a sentence or two is not that big of a deal, but when you multiply it times 10 across the day, it adds up. So has anyone created even the tiniest of templates to help them out?
We use smart phrases for just about everything. I am actually working on a long list of smart phrases that we can put in the ABS for the things that we do often with patients, like emotional regulation and calming techniques and all of those things. But I have them for websites that I recommend commonly. I have them for my attestation of what I put in when I attest for my therapist. I use those for just about everything.
I'm wondering if people, so I am not going to add much here because I've never used Epic. I use Athena. But so as an outsider, it's interesting to listen. Do people, do you have documentation manuals or things that you write down, like the Molly you've shared, or Hannah or Amy, the things you've shared, you document that so that when somebody new comes on, they know how to document? I'm sure you do. And I would wonder if we could share those across the group.
Yeah, we have an EHR team at our organization, and so I work really closely with them whenever there's something specific that we're working on. They create what they call a tip sheet, and I think
Yeah.
they like pull screen grabs and work with Ochin to kind of like create those manuals. So I don't directly make those myself, but I just work with them to pull up what we need. And so that's been really helpful to share and to create our onboarding agenda.
Yeah, Molly is saying you do a 3-hour training to help new folks get onboarded.
Yeah, I second the smart phrases. I even had a smart phrase for, services were rendered in Spanish,
Mhm.
whatever it was. It's just I know exactly what my routine was for sleep hygiene, what it was for grounding, so why want to recreate that sentence over and over again every single time? So if we can just plug those in and create a nice narrative, then do that. Great. I'm curious if anyone here has optimized the scheduling with an Epic for either PCBH or COCM and how that has worked, because I know talking about other departments, finance and leadership, they always want to see that ROI and making sure that you're seeing enough patients and optimizing the time that individuals have talking to patients. And so I'm curious how that's been leveraged. Yes, but I'm sorry, let me back up. And Ben made a really great point here. The clunky nature of documentation does cause financial strain, right? Just COCM, especially because you're wanting to track every single activity related to COCM. And I can't tell you how many times this happened to me. And Ben, maybe you can relate to this. And Jessica, I'll put you guys on the spot. But I would have behavioral healthcare managers sometimes say, well, I didn't document that conversation with a doctor because it was only 2 minutes and it would take me longer to document the 2-minute conversation I had with the provider than it would, and then we're telling them, well, don't take up all the minutes documenting because you have an hour for the entire month. So how do you balance that?
So just to back up, Jessica and I helped a company build a registry, and as clinicians sitting in the sort of the development and with the engineers, we were constantly saying, "Hey, documentation has to be super super efficient, easy to do, click boxes and smart phrases and things of that nature." So we've got the clinician's point of view in the engineering team, so that was really helpful. I've never used Epic, so I can't speak to that, but I think clinicians have to be in those boardrooms with Epic.
And the only other thing that I'll add in addition to what Ben's highlighting is I think this has a lot to do with care team job satisfaction and burnout. Daniela, you started to talk about this a little bit earlier. So it's the financial sustainability piece through the ease of documentation and capturing time and tasks. And then also being mindful of the burden that places on the care team. We really want these people to enjoy their job and be passionate about it and focus on the good work that they're doing, not the administrative burden of trying to capture every minute. And if you leave those minutes on the table, then you're not able to demonstrate to the higher ups at your org the value of the program. And then you don't have the financial sustainability. So it's definitely a juggling act.
And maybe I'll back up and highlight what was shared earlier about the smart phrases. So we might not have necessarily a template for every single thing, but we can have a smart phrase to facilitate that ease of the documentation for the smaller, lower minute activities. Then by all means, let's do that. Right. Okay, now I forgot what question I had asked previous to this. Oh, the scheduling. So,
Scheduling.
yes, thank you, Stacy.
Daniela, do you mean just about how we utilize the schedule for warm handoffs and how we add them on throughout the day?
Yes, I'm curious how folks have worked around that obstacle of creating enough availability for warm handoffs while also creating the space for follow-ups, not creating a 6-month waiting list while being able, just
Yeah.
another balancing act.
Well, I definitely don't think this is, I'm I don't know if this is the best or right way, but I build our templates, our BHC's templates for three, like every other. So there's a 30-minute blocked for warm handoff, and then 30-minute open, 30-minute blocked with no more than 6 open slots per day for follow-ups. And the BHCs have access to add their own appointments to their schedule throughout the day for the warm handoff. So we don't have to wait on the MAs or the front desk to add them for us. We can just kind of do it all and go in the room, and that helps it be a little more efficient. But I've also had my team, there's been like some confusion in the past in my organization about if you should put the 8-minute consults on the schedule or not. And so I have them put everything on there, and we just use a no bill code. That's kind of how our billing team likes us to do it, but at least we can see how many patient encounters we've had that way. So that seems to be working okay for now, I think.
I think it might seem cumbersome, but I do like the ability or the option to pull a report for encounters and being able to track that information.
I think it's interesting because it's like this constant back and forth of so right now the big thing is like slot utilization, right? And questioning even like why is the warm handoff block, right? So it like skews data, right? And then people come and they look because if you have 6 available slots, right? But then you're booking in, which is beautiful, right? Like yes, yes. Then it looks like a higher utilization. So then the question then lends itself to say like, okay, well then we need more BHCs, which is great. But then you dig a little bit more into the data and you're not getting the billable encounters, right? And so it's this constant back and forth. And I know I'm not unique in this. And so there's always that balance of like, how many warm handoffs do we put? So then we have like this slot utilization versus arrive utilization versus all these other components. And I don't think I have a perfect answer. This isn't to be a perfect answer. It's more of just to create more conversation on how we can do this better. But that's one of the things that we face, right? Is that we put in these slots for warm handoffs, but then they're used and then it looks different. And then we have people questioning it and we're trying to be like, no, this is a good thing. And yeah, everyone looks at the number and takes a different response off of it. I can't speak to COCM. I'd be curious about actually how like an Epic build of 2 of those things. So if anyone has input about 2 of those things, because I can't imagine having to track every single minute of my day to then lend itself to a billable perspective. But I do certainly understand and honor that like that's a great way to do it as well. I would just need more training and understanding how those 2 overlap.
Can I, before anyone answers, I just want to add, Molly, my argument was always, so how do I track the minutes I spent tracking minutes? Like it was very annoying. And you want to capture all the work that you're doing to really reflect, the power of this model. How are you helping the patient by having a conversation with the psychiatrist, with the doctor, and following up with the patient, and, making sure all the dots are connected. But who wants to track minutes, and then if it doesn't add up at the end of the day, like, are you reprimanded for that, and just the approach that leadership has. Again, for me, I come from county services, so COCM probably broke me in because at the end of every single day, I had to submit an activity sheet with totaling exactly 480 minutes. If it was 481, why did you work over? If it was 479, why did you not work enough? So it's a tedious process. So if I have seen some versions of Epic that literally have a timer. I have seen others where you're doing like an episode of care for the month, where you add up all your minutes over the course of the month and you wrap it up at the end of the month. I've seen others where you open up the episode of care when you start COCM and you close it after 6 months. So there's a lot of variation with that. I'm curious if anyone has had experience with COCM here, or are we a PCBH group?
Can I ask a question, Daniela? As I'm listening to everybody, it seems like you all have spent a lot of time adapting Epic to your particular instance and needs. Just out of curiosity, like what's the kind of average amount of time that you guys have spent, updating or changing or, adapting Epic for your usage?
When I first came to the organization, standardizing our templates was my risk goal for the year for our compliance department. So it took me an entire year to build, but it was I feel like I spent a little bit of time every day kind of like tweaking and improving and reviewing and considering. So I don't know. It's that might not be everyone else's experience, but that's been mine.
I can just say too, we've spent many hours in Epic. I agree with Hannah. We're constantly tweaking. Epic for us has quarterly upgrades. We have monthly upgrades within our organization that I take part of. We have monthly, like we call it charting the course, and their upgrades and then or changes. Sometimes they affect our workflow in COCM. Sometimes it's just the medical providers. But we have to be on, and then we communicate to our staff. So I feel like it's a part-time job on its own, just keeping things updated. And I actually initially created a manual 80 pages for our workflow. It was redone by a couple other of our collaboration managers recently. I think it got up to 90 pages, but again, to keep it completely updated, you'd have to change it on a monthly basis. So it's a lot of work.
I thank you for the comments. I like I said, I'm not familiar with Epic, but when I would be creating templates in Athena, it was completely dependent on having somebody in IT that I could rely on and who was really enthusiastic. And a lot of times I would go to her and just say, here's what I need. Like, what can we do? And can we build that? Right. And so I wonder if it's the same with Epic, if you're hamstrung by your IT people, or can you create your own?
Fortunately for us, we have a couple people on our team that are just really good in creating all the drop-down boxes. They've figured it out.
Okay.
So fortunately, we would be having to create a project every time we wanted to do a template change. So we've been able to figure that out on our own, thankfully, but otherwise we would be using our IT.
Mm-hmm.
And we'd never get anything done because they're busy.
I think we're really seeing the beauty and the struggle of Epic, right? The beauty of is, and the way I think why so many organizations are sold on is the customization level. You can create your own product, but then you need an entire team to create your own product, and having to figure that out and refine it and fine tune it every single T90s every month. You would need an entire team just to make updates to your playbook, right?
So people are just saying in the chat, like some people can create the updates. Some teams internally don't want you to do that. Probably also depends on the size of your organization and your internal rules.
I also think that we're forgetting a major element too, is how much your organization wants to keep paying Epic for certain things. And so if they think that they have the internal resources to not have to pay extra for Epic or build this or build that, right? They're going to use their internal resources and contract less and less money. At least that's my experience. And I understand that. I absolutely understand that. But I think that that also hinders knowledge and awareness of like what Epic can be programmatically if we have people that are only trained on certain levels and then they're either not getting paid to do additional training with like going out to Epic to do ongoing training. I think that that does hinder things. So like all the training that is received can be like internal, and that's not always great either.
So Jim is asking how many of our organizations are using Epic for both specialty BH and COCM?
So we have multi levels of care at our organization. So we have specialty outpatient mental health, both outpatient, IOP, PHP. We also in our hospitals have inpatient psychiatric treatment as well. And then on our primary care side, we only have at this time PCBH as our integrated care model.
Yeah, so it looks like a lot of organizations are doing the same, using it for both or many levels of care.
I'm wondering for those organizations like Molly or even Saba, how easy is it, or is it possible to see, like, if you're in the primary care setting, how easy is it for you to go into specialty mental health and see if they are in therapy? Like you, like, or
Very easy.
okay,
They just
Saba. Okay. I'm always curious for that.
Middle ground, I mean, technically I can see that they've had an appointment, but everything's break the glass.
Okay.
Or just not, some even have documentation that's marked as sensitive, which is one of the things that I struggle with the most in Epic. A sensitive note means that you as the provider are the only one that's able to see that note. No other providers can see that note. And I find that like even in traditional outpatient mental health, like not appropriate. But that's what our Epic has. So some notes are marked as sensitive, so only the provider that wrote that note can see it.
So Ben's asking what's break the glass. That would be helpful for me too.
So there's two different, my experience of Epic is there's actually a couple different things. So you cannot share, you have the option to not share with a patient's MyChart, which is completely different than break the glass or anything else. You do have to designate why you're doing that because it does go against the CARES Act to withhold that information from getting into MyChart. You have break the glass, which means that you have to enter why you're looking at that note, and it can be for a variety of different reasons. It can be direct patient care, billing, administrative reasons, but you still have access to that note. You just have to break the glass in order to see it. And then in my experience with Epic, you also have a sensitive option, which means that once you mark that note, no one else can see that note except for you as a provider.
And
So I'm curious why we don't break the glass very seldom. We are as providers, and then we can go into different departments. So various clinics, I can put myself and assimilate myself with them. And then I rarely have to break the glass. Occasionally I do, and I'm not exactly sure why, but I can review hundreds of patients and maybe have to break the glass 4 or 5 times for something. So it must be on how you are assimilated, or you have a certain, can't think of what I want to think of, but like
permissions.
Yeah, that's,
Yeah.
thank you.
the way I've seen it, and believe I've had organizations that their COCM was behind Break the Glass because it was categorized as mental health, like specialty mental health, and like a higher level within HIPAA type of thing. So not even the medical providers would have access to those notes. And internally for Epic, the breaking the glass and typing in your password is a way to track everyone that has seen this note, and in some, I even had to justify, not only put in my password, but justify like why I was coming into to read this note, Ben. So, and the sensitive, I've seen it too. I think I've used it, Molly, for specialty mental health, but when it was like a trauma processing, like you don't want that sensitive information to be available for everyone, and or higher risk, with oh gosh, like violence and in the patient being at risk and protective custody. There you go. So I think it just depends, but ideally the whole reason we're in integrated care within the medical setting is so that everyone kind of is on the same page and is able to treat the patient. So we're having to break the glass. Do you see a medical provider typing in their password a couple extra times to read a note when they're busy throughout their day? They're not going to do it. So again, I think this is a lot with the compliance and legal teams, how they define what integrated care is and what restrictions they're going to put on
Mhm.
the documentation for integrated care.
A lot of people are saying in the comments that their orgs put all employees under that, which makes sense to me. But I hear what you're saying. Yeah, if the medical provider has to do even one extra step, when sometimes VH is a little bit, in my experience, a hard sell anyway to them sometimes, then they probably won't.
I had one organization that they were so strict with COCM that you couldn't even see, like forget break the glass to like read a note. You couldn't even see my documentation on like the list of notes or like my interaction unless they knew to search for it.
Mhm.
I mean, that was a flop.
At that point, though, it's like, why be integrated behavioral health, right? And
Right,
we've had that situation too with like, well, how do you document? You document in a psychotherapy note, and we're like, no, we don't document in a psychotherapy note. We document in a progress note, right? Like these are progress notes. Psychotherapy notes are different, and they actually should be, kept in private. But we don't even have the option for psychotherapy notes, and that was a decision. We were offered it, and we said no because that didn't align with PCBH and integrated behavioral health as we saw it. But many compliance and legal have tried to push that back on us, saying that that's what we're doing, and it's not. So
Molly, have you had success with those conversations sort of pushing back, or like maybe not pushing back, but having to explain what you do?
So
And
there's been some great hills that we have climbed up and accomplished. I think that it's cyclical though.
yeah, right.
At least in I've almost been 7 years now at my organization. And started no leadership and then kind of varying leadership as I've gone up. And I've seen it, you get one person in legal that they interpret the law in one way
Mhm.
and they don't see the fact that it's a progress note, and they say anytime that you're using a psychotherapy code,
Mm.
therefore you should not have you should, your note should be behind glass. And there's a lot of education and re-education, and I think the CARES Act opened it back up again, which was fine. I'm happy to do that. But it gets a little redundant and tiring sometimes, especially when this is an organizational goal. So yeah.
And I wanted to add to that, Molly, that the training of staff to not document a PCBH or COCM note like a psychotherapy note so that we can keep it without breaking the glass, right? We don't need so much detail.
And there's nothing, and a lot of that education too about what so like in the state of Pennsylvania, we still have to bill psychotherapy codes, right? 90832, a very common code that we use. And people see that and they say, oh, psychotherapy code, and everyone gets upset. And it's like, Well, no, and let's look at what is needed to document that code and how we're fulfilling that in our note. It's a lot. It's exhausting sometimes. Again, it's work that it's worth doing. I just wish that sometimes I like to say that like if Epic knew about integrated care, they would be on board and giving like best practices to these organizations that might also help in clearing the pathway a little bit easier for us to say like, hey, this is how COCM is practiced and this is how PCBH is practiced. And these are the best practices that we've created, you know, to help in navigating it. Because like, I don't think COCM should ever be behind Break the Glass. I don't think what I should do should ever be behind Break the Glass, but I feel like that's often the scapegoat for organizations. It's like, this is how we were taught.
Right. Any comments or about measurement-based care in Epic and how that works?
Apparently it doesn't.
Some are using flow sheets for PHQs and GADs. You know, Ben, sometimes people want to jump in on your question and other times,
I don't think it's a lack of wanting to jump in, Stacy. I think sometimes it's just the lack of being able to
maybe people don't know. Yeah,
to like figure it out.
sure.
It's hard.
I just want to jump off of Ben's question. One of the things that Ben and I experienced early on in our program, which is pediatric and adolescents, shout out to Caitlin Lull, who is one of the care managers in our program, who's on the call, is the complexity of screening protocols for pediatric and adolescent populations, the ability to engage with parents and stakeholders, but also having a screening protocol that maps to age and stage of development. So the adult population, a little bit easier to streamline with GAD-7 and PHQ-9 if you're predominantly serving mild and moderate depression and anxiety. But the pediatric and adolescent world is definitely more complex. And I think something that when it's not streamlined, it throws, it slows the team down and creates an administrative burden, as well as sort of lack of streamlined data for the team to work with.
I know there is, if we check out the CFHA calendar and additional work groups, I know there is a major push right now or call for measurement-based care across both models. And I know COCM naturally lends itself a bit more to measurement-based care versus PCBH, but looking to push that a little bit more as well. So there's other groups where there's more conversations to be had for that.
I would also say too, Epic does have the ability to like push out these measures. I argue all the time that PHQ-9 and GAD-7, we also routinely do the audit and the DAS for every initial, is not where I want to be. I would love like a more robust BH Vitals that has like branches and like we all have ideas, but this isn't where we are right now. At least we are with our Epic. The other thing that I will say about Epic that's also a huge barrier is you have to pay for a lot of measures. And if the organization, so Epic may have paid for the measure just to have it, right? But then your organization needs to pay for whatever tool, if it's one that you need to pay for, which many are. And so then your organization has to go through the process to purchase the rights to have that measurement tool in the flow sheets. And it's often based off of the provider size, right? Or the organization size, like how many times is this going to be utilized? And so I've come across that quite a few times when we try to get various tools uploaded in our system. Yeah, it all adds up. So, right, like, so but Epic does push it out. So to your point, Jessica, about like things that kind of clog the wheels a little bit, we've found that when we push it out, not so much for our peds or adolescents, but certainly our adult population, when we push it out as a pre-check-in, we do get about a 50% response rate. So that does help us as providers lower the administrative burden of having to administer them. So, yeah.
That's super helpful, Molly. That makes sense. I think when I think measurement-based care, I initially think screening tools as opposed to the more advanced dashboards and things. So I would assume those screening tools are in there, but that makes sense if you have to pay for additional ones and things like that. Great. We have about a few minutes left. Any other last questions or things people were hoping to air out today? Or Daniela, did you have any other final thoughts?
I think every time we have one of these conversations that we walk away with saying, yes, it's hard and it's always a work in progress. But I want to thank all the CFHA members that are always so willing to give of their knowledge, their experience, and time to share and help others that are going through it as well. But if we know anything, I think it's the fact that it can be done, and there might be some hiccups, but we figure it out for our organizations.
Jim has a quick question. How are COCM vendors interfacing with Epic PCP users?
Jessica, you want to take that one, or?
Can you give clarification around the Epic PCP user? So meaning the PCP team is using Epic, but is the collaborative care team using Epic as well?
Yes, so I'm trying to figure out for vendors who are not necessarily integrated with a PCP practice, if one is using Epic and the other isn't, how are they doing that integration?
So there's a number of ways the integration can happen, but most platforms, and Mira in particular that Ben and I are partnered with, are designed to stand alone unintegrated as well as integrated. What we tend to find is that this concept that I'm hearing a lot of people talk about around getting IT time and resources internally does seem to be a holdup for integration. So Mira specifically has an in-house engineering team that will dedicate time towards integration. Integrations can happen in a number of ways, but are often limited by the internal IT resources, or in some cases by the EHR and the way data is structured. So ideally, there is a workflow to operate unintegrated and then to have clear guidelines for when information lands back into the EHR and how it maps back to that. Ben, do you want to add more?
I would just say that there's different types of integrations and platforms for that, all HIPAA compliant. Some that are more advanced cost money on a sort of per interaction between the Epic and other external platforms.
Okay, thank you both. All right, well, I think that that concludes the conversation today. Thank you all so much for your participation. Thank you, Daniela and Molly, especially for just sharing your thoughts on this, and Ben and Jessica and everyone who came today. Please keep an eye out for next month's conversation, and we will hopefully see you then. Hope you all have a good rest of your day.